This is the review of the components of our 4-valve AMBU BVM system. This is the oxygen reservoir. This line is for the supplemental O2. In the cylindrical piece, there are 3 valves that direct flow. We'll zoom in. This opening here is for the outside air to be able to enter the BVM, and it's also a relief valve. So if we rotate here clockwise from the supplemental O2 port, this first valve right here prevents overflow from the supplemental O2. So if you have too high of rate that would give the patient ventilation, this valve will open and release the extra. We roll over here, counterclockwise. Here's the outside air port. This valve, if you do not have enough in the reservoir, it allows for room air to pass into the main bladder so you don't suffocate the patient. The main bladder capacity is about 1,200. One squeeze is between 5 and 600 mLs. The reason for the range is based on hand size. It's only supposed to be intended use is one-handed operation, never two. The reason for that is to come over here to the pressure valve. If you were to squeeze over 1 second like we're taught, you don't get a huge rise in pressure. If you do it very quickly, you get a huge rise in pressure. On the pressure valve, we want to ventilate no greater than 40 until the L is okay, no greater than that. Moving on to the main valve, or the ductbill valve or the ventilation valve, either way. It looks like a ductbill and it prevents backflow. So when you ventilate, it opens, and when the patient exhales or you're not ventilating, it closes. So ventilation, patient exhales, closes, and the air comes up and goes out the exhalation port. So you can see, if we're not using this valve here, and this is open, it's just continuous with the open air, and the patient can pull outside air. Start with your mask, bridge the nose, make sure the mask encompasses the entire mouth. Use your 2-thumb technique, using the strongest finger, index, middle, ring. Open the airway. From here, you'll transition to your CE clamp after it's open. Then you'll put your bag on it, obviously with an ETCO2, and you'll ventilate. So we're going to demonstrate the importance of using the PEEP valve on this 4-valve system here. So like I talked about earlier, without the PEEP valve, this becomes an inlet for oxygen, and it mixes room air with 100% from the bag, and that's why we always use a PEEP valve. So first we'll demonstrate it without the PEEP valve, and then I'll add it. So what I'm going to do is I'm going to occlude the inlet here from the bladder. So now they cannot breathe through the bladder, it's only coming from the outside. And I'll put the mask on and breathe. Okay, so I'll have it occluded. Add the PEEP valve. And we'll try it again. Unable to move any air. This allows for 100% FiO2 on every breath. We'll finish up this video talking about ventilation rates, Untitled SpO2 goals, and then just some notes. So for ventilation goals, ACLS and a lot of the textbooks will teach to give 1 breath every 6 seconds. Here at HGH, we're not going to do that. The only time I think is reasonable is when you have no monitoring available. I mean, it's no cardiac monitor, so you can't get SpO2 or Untitled monitoring. Then I think using 1 breath every 6 seconds is probably okay until you can get that monitoring on. For SpO2 goal, this is a variable number here, but I want you to think, generally speaking, we're looking for 90 to 94%. And the example of it being variable is the end-stage COPD patient. You know, they probably live 86 to 88 all the time on oxygen with all the meds. So maybe 90, 94 isn't necessarily reasonable for them. So always use your clinical reasoning, your partner, supervisor, etc., to help kind of define goals if you need help. Entitled goal. So there's 2 general situations which you'll encounter: high and low. For a high entitled, meaning high outside the normal range of 35 to 45, so talking about high as 45 plus, generally speaking, you're going to want to maintain a goal of 40, which is right in the middle of the range. For a low entitled, however, again, low being outside the normal range of 35 to 45, so less than 35, we want to maintain whatever the baseline or the initial value is. The example for this one is a patient that is a DKA and they're so acidotic they've become altered, and so you need to take over ventilation for them. If you were to move it to the normal range of 35 to 45, they'd probably die. You'll find them in 15, 16, 17 for Untitled, and you want to maintain that range. All right, last thing, couple of notes here. For the BVM, anytime that you use it, it's an opportunity to use a mechanical ventilator. Because we don't do it every day, the opportunities are really sparse. You should take every opportunity that you can to use the ventilator. Even if your bag's in for 5 minutes, it's an opportunity to get it set up. Okay, for spontaneous breathing patients, just remember, they are able to receive volume through the BVM, meaning when they breathe and you're not bagging, they still are able to pull volume through the valves. Now the volume is dependent on inspiratory force. Someone who's got a really strong inspiratory force, of course, they're going to get a high volume, versus someone with a really weak inspiratory force or ability to breathe in is going to get a small volume. Last thing to talk about is the supplemental O2 flow rates, meaning what you're going to set on the little Christmas tree. So when your oxygen is not limited, like you're in the ambulance or you're in the ER or whatever, you want to turn it to the maximum flow rate possible. That's going to ensure the patient doesn't overcome the reservoir. Now, when your oxygen is limited, means that you're in the house and you have a decylinder, maybe only one, and you have limited hands. I want a minimum setting of 10 liters per minute. Once you start there, you can then titrate that based on the patient's SpO2. So if you do 10 liters a minute and the reservoir bag is full and they're at 99%, then you can come down on the flow rate just to maintain the SpO2. Because ultimately, having a lower flow rate will give you a much longer time with the oxygen, and maybe you don't have hands to get more oxygen. So if you run out, and they'll return to the initial baseline SpO2, and you don't want that. Last thing is be cognizant of what you have on hand. So if you're inside with a decylinder, and it's only going to be the two of you, nobody else is coming, be cognizant of what you have, your oxygen available and your resources. And maybe it is you leave someone immediately while they're BVMing and you get the stretcher and you leave so that you can get to the ambulance where there's more oxygen. Okay, this concludes the BVM video.